Hello and welcome to Pulmonology Read Aloud. This is Dr. Anshu Maneja Arora, and I welcome you to my channel where I discuss and read aloud all evidence based information in pulmonology. So let's get started with today's talk. Today, I will be reading aloud an article which is a very interesting article by Professor James Chalmers and his group on bronchiectasis management in adults, the state of the art and future directions. It was published in the European Respiratory Journal later in 2024 and is one of the most updated articles on the newer updates in bronchiectasis till date. This is my previous video about bronchiectasis guidelines, which I published almost a year and a half ago, where I talked about the BTS and ERS guidelines for management of bronchiectasis in adults. And I also discussed about the Embark registry from India, which did give a lot of insight about how bronchiectasis varies between Indian and European subcontinent. So today we're moving a step ahead with one of the latest updates in bronchiectasis. Let's get started. So, in the last 1 to 2 years in bronchiectasis, there have been a lot of updates. These updates include understanding the heterogeneity of bronchiectasis because that is one of the most challenging aspects of management. Every patient will have a different course, and every patient may respond to separate different medication. Now, recently, a lot of phenotypes and endotypes of bronchiectasis have been identified. This is mostly in lines with what we are seeing with other diseases like COPD, asthma, ILD as well. So, we are now trying to find treatable traits in bronchiectasis patients so that we can optimize the medication and the management. There are also newer drugs, newer developments, and newer protocols that are very promising and underway. And there is a novel anti inflammatory therapy that has already been approved by the FDA, which has been launched for bronchiectasis management in non cystic fibrosis bronchiectasis. So, bronchiectasis, you would remember, would be considered as an orphan disease in the past. But that is a thing of the past. Bronchiectasis is now already recognized to be a very common disease. And as definitions are evolving, we've come across definitions that have been used in clinical trials and definitions that help us in our day to day practice. According to this recent paper by Dr. Chalmers, bronchiectasis should be defined radiologically by a permanent dilatation of the bronchi and clinically by cough, sputum production, and recurrent chest infections. So it's actually a permanent dilatation, and the triad of the symptom makes it a classical bronchiectasis. The exacerbations of bronchiectasis are defined as watershed events in the natural history of the disease. And it has been seen that patients with frequent exacerbations can have as high as double the mortality rate compared to those who do not experience exacerbations. So, exacerbations and their management is really significant in the whole timeline of a bronchiectasis patient. Coming to the pathophysiology, in my last talk on bronchiectasis before this, I had mentioned how it is considered that there is a vicious cycle involved in bronchiectasis, which includes inflammation, which includes inability of mucus to be regulated properly, and infection. Now, this pathophysiology, which was initially just a vicious cycle, has been replaced by a vicious vortex. So, the cycle has become a little more complicated. And this model of the vicious vortex incorporates complex interaction between all these three components of the bronchiectasis cycle. For example, if you have a Pseudomonas infection, that does not only induce neutrophilic inflammation but also directly affects mucociliary clearance through the action of the toxins, the celiotoxins like the pyocyanin. So when the ciliary beat frequency will reduce, naturally the mucus clearance will reduce. So the same organism which is causing the infection is inducing inflammation, and that inflammation is also affecting the ciliary clearance. So, bronchiectasis is an inflammatory disease, and this imbalance between the pro and the anti inflammatory signaling is the one that will ultimately cause the recruitment of inflammatory cells, and this self perpetuating cycle or vortex of inflammation goes on. So when you look at this figure, this clearly shows us how the interaction is not between just one component leading to the other, but all of the components are interacting. The epithelial dysfunction, the mucus hypersecretion, and the ciliary dysfunction, this together may impact the chronic infection rates and the bacterial virulence. It may impact the neutrophilic inflammation, the T cell infiltration, the immunodeficiency, which all together may lead to lung destruction and bronchiectasis. So it has become more like a complicated vortex. There's also been, as I said, a lot of emphasis on identifying targetable traits, targeting the treatable traits in pathophysiology of bronchiectasis. And this beautiful diagram taken from this paper is self explanatory. What it says is that your diagnosis depends on your symptoms and radiology, as I mentioned. So, your definition encompasses how you will diagnose the disease. Once you have diagnosed the disease, you're trying to identify the etiology of bronchiectasis. So, the second step is the assessment, which will involve trying to find out which bacteria or mycobacteria or fungus could be involved, trying to see the lung function of the patient, trying to look at the exacerbation frequency of the patient, trying to look at the disease severity of the patient, the symptom severity of the patient, and simultaneously also assessing for all these factors. So, if the cause comes out to be a mycobacterial infection or a non tubercular mycobacterial infection, we need to treat the cause. If the cause is ABPA, allergic bronchopulmonary aspergillosis, we need to manage it to prevent bronchiectasis progression. If the cause is immunodeficiencies, we have to work on it. If the cause is alpha 1 antitrypsin deficiency, we need to work on it. We also need to work on targeting the symptoms of the patient. If your patient has dyspnea, we know we need to target with bronchodilation, with pulmonary rehabilitation, with exercises. And if the patient has repeated infections, we know we need to target that, maybe by giving him prophylactic medication. And simultaneously, where diabetes, where asthma, and other diseases can increase the problem because of their comorbidities, then these also need to be managed. Once you've made a plan, the next step is to look at the treatable traits. Is your patient undergoing airway inflammation that can be managed? Is it a neutrophilic inflammation? Is it an eosinophilic inflammation? Is the patient needing eradication uh, of pseudomonas or is needing antibiotics? Or is your patient suffering from mucociliary clearance related issues and you need to add that? And this little chart also gives us the future of managing all these treatable traits in the future. And I will come back to this chart when I talk about it in the later part of my talk. So, first of all, is the diagnosis and the treatment of treatable etiologies of bronchiectasis. Now, here, if you find out that the patient has an NTM disease, how would you diagnose it? It would be diagnosed by sputum culture for mycobacteria. It would be diagnosed when you isolate NTM species in more than two cultures, or you isolate it in more than one bronchial wash, and a biopsy is compatible. Remember, when we detect NTM, non tubercular mycobacteria, incidentally in one of the sample, it does not call for treatment. Remember that when we are treating NTM disease, there has to be some involvement of structural abnormality where we can attribute it to NTM to start treating it. So here, whenever you see bronchiectasis and you isolate NTM, you would want to treat it. And the treatment would include a combination of antibiotics for 12 months after the sputum culture conversion. And we have to treat the NTM according to the species that is involved. So the guidelines till date, the ERS and the BTS guidelines recommend that you must do mycobacterial sputum culture in all your patients with bronchiectasis to be able to identify them and then treat according to the guidelines for treatment of that disease. Second most common factor is ABPA, and in Indian setup, it's a very, very common factor for central bronchiectasis. Here, the diagnosis becomes a little simpler because we have the serum IgE total, we have the aspergillus specific IgE for aspergillus fumigatus, and then we have the skin prick test, and we have the IgE test and IgG test and IgM test for aspergillus specifically. The mainstay of treatment is systemic steroids and addition of antifungal or antifungals in case of recurrence and treating it according to guidelines. For patients where immunodeficiency is suspected, a serum immunoglobulin level helps. An IgA, IgM, and an IgG deficiency or a subclass deficiency can give us an answer, and immunoglobulin replacement is usually the treatment. The guidelines recommend that in all patients with bronchiectasis, you should preferentially do these serum immunoglobulin levels to be able to identify them. And the BTS guidelines also recommend a pneumococcal IgG to look whether you will have a vaccine response. However, we don't do it so frequently in our day-to-day clinical practice. Alpha 1 antitrypsin deficiency is the next etiological diagnosis where a serum alpha 1 antitrypsin level and a genetic testing will help, and an IV augmentation can be done wherever available. The guidelines recommend that this testing also should be done in patients who have pan SNR emphysema, especially who have bronchiectasis with basal pan SNR emphysema. And presence of this basal emphysema or airflow obstruction can suggest that you have to look out for alpha 1 antitrypsin. So, a bronchiectasis patient with emphysema could be one clue for looking out for this problem. Coming to this figure given in the guideline, which really talks about how the etiology, the comorbidity can affect the outcome of a patient of bronchiectasis, and you can retrospectively go and diagnose that, or you can take it forward from there and see what you need to do in a surveillance. For instance, patients who have rheumatoid arthritis, inflammatory bowel disease, and primary ciliary dyskinesia are more prone to increased exacerbations in bronchiectasis. They are more prone to mortality in bronchiectasis, and they are more prone to chronic infections with Pseudomonas aeruginosa. Also, patients who have comorbidities like asthma, COPD, and rhinosinusitis do have a poorer health related quality of life, a more severe respiratory symptom because the asthma, COPD also adds to the airway obstruction, and these patients are also more prone to much more exacerbations. Patients with non-respiratory comorbidities like gastroesophageal reflux disease or depression or cardiovascular comorbidities can also have an increased exacerbation and a poorer health-related quality of life. But if a patient has a cardiovascular disease with bronchiectasis, remember the mortality may be higher. And so will it be higher if he has an asthma or a COPD or he has rheumatoid arthritis. So these are our red flags wherein you have to really closely monitor these patients. So this was my last video again, which was the part 2 of my bronchiectasis series a year and a half ago, where I also touched upon the airway clearance techniques and the takeaways on airway clearance from ERS 2017 guidelines. Taking it forward, now, according to this paper, the international guidelines now recommend that all patients with bronchiectasis should receive instructions in airway clearance technique taught by respiratory physiotherapists. So it's very, very important that you ask a respiratory therapist to teach your bronchiectasis patient about mucociliary clearance. And it's not just for the patients at the severe end of the spectrum. The moment you identify and diagnose, it's really, really important because there are so many abnormalities in the mucus of bronchiectasis patients that it mandates airway clearance. It's an absolute necessity. If you look at healthy people, mucus in bronchiectasis is much different. It has a higher mucin, it has both high MUC5B and 5AC, it has higher percent solids, it has higher osmotic pressure, and it has increased elasticity and viscosity. So here, if you are able to teach mucociliary clearance and airway clearance techniques right from the beginning, it will go a long way in improving the morbidity of your patient. So as I said, mucus in bronchiectasis is more viscous, more solid, more elastic, and so mucoactive agents may be required to improve its overall hydration, to reduce this viscosity, and to be able to stimulate the cough to aid mucus clearance. So what do we do in that regard? So if you look at this flowchart again, this image again, which I had discussed earlier, we can now break down individual treatments starting with mucus. So the current treatment available for mucus therapy involves physiotherapy. It involves inhaling hyperosmolar agents. A lot of time, hypertonic saline is given, exercises, and pulmonary rehabilitation. But what is changing now is that there are ongoing studies for CFTR potentiators, studies which are looking at ascorbic acid and glutathione for mucus clearance, hypertonic saline with or without carbocystin. We already have erdostin, which is now available and which is being used, which was not available to us earlier in oral form. The nebulized ENaC blockers for primary ciliary dyskinesia are under study, and inhaled mRNA therapy for primary ciliary dyskinesia is also under trial. So we are having a lot of potential treatments to come in the future. For now, we do have inhaled hyperosmolar agents. Oral erdostin is now available. We've always had NAC, and now we will be having more in the time to come. This is again a flowchart from the ERS 2017 guideline on mucociliary clearance, which I discussed in my last video. Basically, you need to assure that the patient knows postural drainage. You can also ask him for expiratory flow modification by doing a lot of physiotherapy techniques like exhaling against a closed glottis, or by huff and cough and ACBT, or active cycle of breathing techniques, where patient is likely doing a box breathing technique, and in that he's able to exhale. We can also use PEP devices, which are gaining more momentum and becoming much more easier to use, or oscillatory PEP devices, the Flutter, the Acapella. We have other devices like the Aerobica device, which is being marketed in India, and so many more, which are now available. Exercise intolerance is the second part of chest physiotherapy, where aerobic training, strength training, and physical activity is very important and is taken by the respiratory therapist. And respiratory muscle weakness training by inspiratory muscle training is also a part of this physiotherapy. How about the inhaled hyperosmolar agents that I mentioned and mucolytics? So we do have a lot of oral mucolytic agents, and we also have nebulized hyperosmolar agents like mannitol and hypertonic saline. In fact, dry mannitol and its inhalation in a solution form has been under study for a long time. There are certain oral mucolytics, as I mentioned, N-acetylcysteine, carbocisteine, and erdostin. They have been used typically in patients with COPD and have helped, especially in the chronic bronchitis types. So they are under study for bronchiectasis also and are also being used. The next part of treatment is antibiotics, bacterial infections, which is a very, very important part and often a menace to treat. Currently, we have both eradication protocols and we also have certain inhaled antibiotics. In my previous video last year, I had discussed how inhaled tobramycin, inhaled um, colistin is available and are being tried. And then there are protocols for management of Pseudomonas aeruginosa, as in when a patient is detected to have Pseudomonas for the first time or recurrent Pseudomonas infection. I am linking that video again with this video so that you can go and refer to it also for all these eradication protocols. But what is new is that there are newer studies on inhaled colistin, new studies on inhaled aztreonam, IV Dremubamab, and phage therapy that are coming up and maybe a future of bronchiectasis management. This is an exhaustive list of inhaled antibiotics that are being studied, and of note is that in future probably inhaled antibiotics will become the new inhaled medication of bronchiectasis patients. So here ciprofloxacin in the form of DPI or dry powder inhalation, ciprofloxacin DPI dry powder inhalation, liposomal ciprofloxacin, in different studies. There are being studied as phase 2 double blind randomized control and phase 3 double blind randomized control trials. The outcomes they are looking with ciprofloxacin DPI are bacterial load, time to exacerbation, frequency of exacerbations, and bacterial load in 28 days of treatment. And these studies mostly focus on around a 12-month interval or 84 days kind of a duration with follow-ups. The study population in almost all of these studies is including patients with more than 2 exacerbations and culture positive for microorganisms. And the main results of the studies that have been done, like the ones in 2013, 2018, have been that the bacterial load was significantly lower, but there have been no significant differences in proportion of patients with exacerbation. So definitely there are new data and which is prolonged time to first exacerbation or reduction in bacterial load. Is it safe? They haven't found adverse effects in most of these studies. Some patients in the study by Wilson et al. In 2013 did develop some level of antibiotic resistance. Another antibiotic that has been very heavily studied is aztreonam. And in a paper in 2014, two phase 3 double blind RCTs were published where two 28-day treatment courses were given with 28 days of treatment in patients who were positive for Pseudomonas or gram-negative organisms, but they haven't found any major significant difference in the quality of life, and they have found certain adverse events leading to discontinuation, but it is still being studied and there are trials underway. Tobramycin, our good old tobramycin, has been extensively studied and I think one of the most commonly used in a practice for Pseudomonas eradication. The studies have looked at Pseudomonas aeruginosa bacterial load at the end of treatment, the frequency of exacerbation, and strictly Pseudomonas aeruginosa colonized patients or one with more exacerbations have been enrolled. They have found a significant reduction in the load of Pseudomonas aeruginosa, the bacterial load, and in safety profiles, some patients have reported a new onset wheezing or chest pain, some resistance to tobramycin, a lot of patients discontinued due to respiratory symptoms. So I think something of note is that when you're giving inhaled antibiotics, you may have some bronchospasm, and bronchodilators given along as a part of treatment may be of help to reduce these adverse effects. Gentamicin and colistin have also been studied in patients colonized, and they have again seen differences in bacterial load. But as I mentioned, bronchospasm with inhaled antibiotics is something that you should watch out for and preempt it. This is what I was talking about, although I'm linking the complete link, but the recommendations for long-term antibiotic treatment say that if your patient has had more than 3 exacerbations in a year and you've optimized airway clearance and treated the underlying cause, that would be the first way. If there is a Pseudomonas infection, you give long-term inhaled antibiotic treatment. And if it's a non-Pseudomonas infection, you give a long-term macrolide treatment. In case there's intolerance or lack of response, you can interchange between the two. Or you can now, because inhaled, in case it's not working, you can add oral medication along with it. And if your oral medication was not working, you could add inhaled along with it. And long-term targeted oral antibiotics can be given. This is the eradication pathway or protocols which are recommended. If you have a first or a new isolate of Pseudomonas, you can have 3 possible and alternate pathways. And after each step, you must repeat sputum sampling for Pseudomonas and go to the next step if the culture is positive. So the first isolate, you consider a repeat sample and confirm. You give an oral fluoroquinolone like ciprofloxacin 750 PD, initially for 14 days. Now your patient needs further treatment. You give an IV antibiotic, beta-lactam with the aminoglycoside, or you can go ahead and do inhaled antibiotics and give a total of 3 months. So basically, before you progress to the next step, you are checking this Pseudomonas. If it's still positive, you're going to the next step. The other way is where you would want to start with IV antibiotics in the first go, beta-lactam plus aminoglycoside. You again, in the initial phase, you give treatment, doesn't work, add inhaled antibiotics, give a 3-month duration. And the last one is starting an oral fluoroquinolone or IV antibiotics. I try to do this in a lot of my patients who have recurrent exacerbations, plus an inhaled antibiotic, which could be, if you have availability of ciprofloxacin plus inhaled colistin. We usually have inhaled tobramycin with us here in India. And after the initial phases, you can just continue the inhaled antibiotic for 3 months. This is a little costly. Don't know how many patients will be able to continue this inhaled antibiotic for 3 months. And so in those cases, oral fluoroquinolones come really handy. The next target is our inflammation. And as I said, inflammation could be neutrophilic or eosinophilic. So currently, to target the inflammation, long-term macrolide therapy is recommended. But there are newer trials with one drug which has already been approved called oral Brensocatib. We'll be talking about it in the next few slides. But we also have newer studies on oral cathepsin G inhibitor, which again works with the similar mechanism on which Brensocatib has to work. Oral roflumilast, the PDE5 inhibitor used in COPDs. Inhaled ultra-low dose melphalan, IV alpha-1 antitrypsin for patients with deficiency. Itepekimab, an anti-IL-33, inhaled neutrophil elastase inhibitor, and cathepsin C inhibitors are under study. Coming to the drug in the market, Brensocatib. So now Brensocatib has been recently approved by FDA on 12th of August 2025. It is the first and the only treatment which specifically targets non-cystic fibrosis bronchiectasis. It's a new drug, and the way it works is by targeting neutrophilic inflammation. The principle is that the neutrophil elastases and neutrophil serine proteases get activated during neutrophil maturation in the bone marrow by cathepsin C. And if you're able to work or using DPP, so if you're able to work and target neutrophil inflammation, then by reversing the DPP1, we will be able to target the neutrophils. So a trial, the Willow trial and the Aspen trial, two trials have been leading in Brensocatib. They took patients with bronchiectasis in a 1:1:1 ratio and gave Brensocatib 10 milligrams, 25 milligrams, or a placebo for 24 weeks. And they looked at primary endpoint of prolonged time to first exacerbation and compared it with placebo and used the inhibitors of these enzymes to target it. This approval, which has come from the FDA, has also been supported by an Aspen trial, a phase 3 trial, where Brensocatib has reduced pulmonary exacerbation in adults and children 12 years of older with non-cystic fibrosis bronchiectasis, right? And this is the first treatment for non-CF bronchiectasis, which is recommended for children 12 years and above. So this is a landmark treatment. It is marketed by the name Brinsupri abroad. So this is the results: 10 milligram, 25, and placebo, available as 10 milligram, and it has shown that the annual rate of exacerbations has been lower, with adverse effects not being significant. This is Brensocatib 25, Brensocatib 10 versus placebo with a change in FVC. So with that, I end this video on the updates of bronchiectasis. I hope you like this content. Continue to read and inspire others. Please subscribe, like, and share Pulmonology Read Aloud and encourage me to make more videos. If you want any specific video content, then please do feel free to write in the comment section below. Thank you. Have a nice day and happy reading.